Hi, Jen.
Hi, Bethany.
Can I give a shout out to Sable? Today is his 5th birthday.
Oh, happy birthday, Sable.
I can't believe I had a C-section 5 years ago.
Your last C-section.
My last C-section. He's my NICU baby, my tubal ligation. I've come so far in 5 years.
5 is different. It's
I know,
not
it's the
toddler.
whole hand. It's the whole hand thing
not
that's really
ready.
getting me. Well, yours is happening next week,
It's
so
happening next
get yourself
week.
ready, girl. Anyways, today we are going to talk about something that I just know you probably have been receiving a million text messages about and calls.
At least, yes.
Because the Retrievals podcast.
The new season came out.
New season came out.
Just a couple of days ago.
Yes, it is highlighting C-sections specifically, so we have to talk about it.
Yes.
And I think we knew when we were entering into this world that we would sometimes have more difficult conversations around C-sections because we preach and want to give the positivity and the knowledge and the support and reduce the fears. But we have to acknowledge that there are people who come out of this very traumatized and giving them the deserved weight of the experience that they went through. So my first question to you, because I feel like...
Let me say one thing quickly.
Okay.
So the first season of the Retrievals was about something that happened at Yale in the fertility clinic where people were getting egg retrievals and they were saying that it hurt and everyone was dismissing women's pain. And turns out, what do you know, there was a nurse that was stealing the fentanyl. So actually they weren't getting any pain medication. So of course they were in pain. So this is about also dismissal of women's pain in the context of a C-section, during a C-section, not about recovery.
Right.
And I know you're right. Actually, I didn't even think about how, I mean, obviously I know this is a difficult topic, but one thing that I do hope, let's say if anyone listens to that podcast, is if we can understand a little bit more about why things work. Because on the other hand, there may be people who are so afraid of having pain during their C-section. And perhaps if we understand more about what the options are, how we treat it, what we can do, obviously if you were never worried about this, then it's terrifying.
I personally didn't think about that in the depth that it gets into with these stories, that there could have been, you always talk about how you do a check, right?
Right.
But then once the surgery starts, then mentally that patient, you've already done that check. I'm just thinking about myself. I would think like, okay, I'm good to go. I'm safe. You as the doctor, you're feeling like this patient is in a safe place. And then things shifted dramatically. And these people, this patient that they specifically spoke about was also a nurse at the hospital where she was delivering, which I think adds another layer of complexity to the whole storyline.
It's a complex one that they chose to highlight. And I totally understand why they did, because, I mean, this kickstarted a whole thing. But you're right. It was a complex. This is a patient who had a lot of fear and anxiety around C-sections, around the operating room to begin with.
Right. So then she entered into the surgery and started experiencing pain. And I think my first question is, why do you think that anesthesiologist did not make the decision to put her under general anesthesia as soon as she started saying, I am feeling this? And clearly from it's so, the way it's told, you really can like visualize what seems to be happening. Her emotions, her physical nature, everything was pointing to she was in agonizing pain, and they continued the surgery.
I think there's one big chunk of that story that I think is missing.
Okay.
Which I want to highlight. But first, I want to say the way that they described it, the patient even says, at first I thought I was panicking. She's had a panic attack. And how many times, I hope I've made this clear, that I firmly believe that there are times when pain is treated as anxiety. And, you know, I've said this with Rachel Summerstein's episode, that anxiety medication doesn't treat pain. We need to be sure, 100% sure, that this is not pain. And then you can attempt to give an anti-anxiety medication, which some people need. So it was a little, you know, she started to panic, and then it was very clear the way they described her punching the drapes. I mean, that is something I have never, I mean, every anesthesiologist knows that this is sort of, you know, something that could happen to various degrees. And the question is, how do we manage it, right? If something were to come up, this is not something we ever want to happen. This is something we actively try to avoid every single time we take a patient for a C-section. Our job is to make sure that we have a working anesthetic. AKA no pain during surgery. And so the descriptions of screaming, stop, and punching drapes, like that is very, very next level. The first thing is if maybe even she thought she was panicking or there was some unclear nature, right? When we talked to Rachel Summerstein, it was like, I felt cutting immediately. I'm trying to go through every single piece of it, right? So they tested the block. She didn't feel it. I'm going to say that saying they tested the block and she didn't feel it does not give me 100% confidence that the block was tested correctly. Like, how do we know exactly?
That's a good point.
One of the questions could be, how high was the block? Like, let's talk about the OB, the way that they test, because that's the definitive one, really, right? So the anesthesiologist should test the block so that they know if they need to do anything more before we even get to the surgeon's test, because you don't want to feel the surgeon's test either. If they test just at the incision, I've seen this, where they test at the incision, so down low, depending on where they're planning to do the incision, and then you should test at the belly button, T10, and they should also not feel anything there. So they weren't that detailed. Did they clamp really low down and she was numb enough low down but not up at the belly button? Did they clamp on both sides? Is it possible that there was something one-sided with an epidural? You're more likely to get a funny little higher block on one side than the other side. So why didn't they put her to sleep? So one is, I have had people have panic attacks, especially someone who has a history of a panic attack. She has actually a history of a panic attack during surgery. I have no idea. I doubt her anesthesiologist knew anything about her history. But let's say I had a good relationship with a patient. She told me how worried she was. She told me she's had panic attacks before. If she thinks at first that it's panic and not pain, and I do feel confident with the test, I think it's okay to try to treat that with IV medication. So anxiety is treated with IV medication. The big, massive gaping hole, and it's really the only massive gaping one that I found. In general, I think it was very well done, the series, was why didn't he redose the epidural? She has an epidural. To me, that is one of my biggest teachings is, why are you ever giving IV pain medication if you have an epidural? How much did he give in the epidural to begin with, is what I would like to know. You know, what was the dosage? Now, I don't know what she needs if he gave me a number of the dose, but I could have some general sense of, did he already give a lot through the epidural or not a lot? You have an epidural in there. And backing up a little bit, we meet Heather Nixon, who's the OB anesthesiologist. This is a name that I know. This is somebody who is a very well-known obstetric anesthesiologist, probably one of the best in the country. Wow. And when I heard her name, I think I was driving, but I would have fallen over onto the floor in shock because I was like, wow, if this story is being told by her, then it must be, she must really believe that something was done, I guess, incorrectly. And I just was so interested to see how it was going to play out. Turns out she's not the anesthesiologist who is taking care of the patient during the surgery, but she put in the epidural.
Right. So you know there was an epidural in place.
You know that I could go through if I didn't know that aspect of it, I would say there are things we do, like a combined spinal epidural versus an epidural, which is more likely to work, or just different little techniques that maybe somebody who wasn't a renowned OB anesthesiologist maybe wouldn't have known. Maybe there was something inherently wrong with the block to begin with. That would be kind of where I would start my assessment of the problem. But if you know that she put the block in, she had some sacral sparing at some point in her labor, which is something that can happen. So it wasn't a perfect block, but sacral sparing, it was fixed. It was able to be fixed with a top up and extra dose. So if you can fix sacral sparing with a top up for labor pain, when you give medication through the epidural for a C-section, that is much denser, much stronger. That wouldn't worry me so much that this wouldn't be a working epidural, is my point. So 2 things he did wrong was didn't put her to sleep when she was screaming in pain, or at least dose the epidural. Why didn't he dose the epidural? Giving all of these, and he also gave far too much. You listened to both, 1 and 2, right? The dosages of medications was out of bounds. It was so much. If you're worried about putting a patient to sleep, I think you should also worry about sedating them to the point of them becoming apneic, not breathing, which puts you in a way worse scenario than just putting a patient to sleep.
Another something that he said when she called the anesthesia, what's her last name, Heather? Nixon. When Dr. Nixon called the anesthesiologist who was taking care of the patient at the time of this surgery, that she said, well, why didn't you put her under general anesthesia? And his response was, because I was concerned about
her airway.
Correct. Why? And is that a thing that is more difficult to intubate a pregnant person? Okay.
Okay.
So talk us through that.
And I've had a lot of our friends text us about this, but I've also had some colleagues text me about this. And it's true and it's not true. So it's a teaching, and it's true that when you're pregnant, there is a higher chance of having a difficult intubation, meaning it's hard to put the breathing tube into the patient, than someone who's not pregnant. But it's been, what they're saying throughout the series is that it's been overblown, and maybe they've put too much fear into all of us around this, because the fact is, when we need to do it, we do it. Like which in this scenario you would say need, but let's say it had nothing to do with what the patient was saying. The patient needs to go to sleep for some other reason, be intubated, you just do it, right? And have the equipment available. So I use video laryngoscopy to make sure that, I have the best possible chance of putting in a breathing tube into a pregnant patient. I think what some anesthesiologists might be thinking when they hear this is a high-risk patient. She is...
Because she's pregnant with twins.
She's pregnant with twins. So she's high risk for a lot of things. And maybe I should only talk about the anesthesia risk, but she says I'm a little fat. So she is, I don't know how much she weighs, but if she's twins and she's 40 years old, first pregnancy, IVF, and twins, that all puts you at high risk for preeclampsia. I have no idea if she had preeclampsia. If you do have preeclampsia, you tend to have more swelling in the airway.
Interesting.
If you're obese, you might have more swelling. She was induced. She was in the hospital for a long time. They don't talk about where she was in her labor at any point, as far as, that she came in the night before, and it was until like the next night, early morning, that she ended up having the C-section. Just there's some pieces that might be missing that might kind of add even more risk factors than the basic information that we know. So high risk for preeclampsia. She's high risk for a C-section. So the airway, I agree with the fact that we have blown it out of proportion and made it too much of an excuse that you really think you're going to kill a patient because you won't be able to intubate her. That risk is not as high as we're making it out to be. But there is a teaching, and I could go on and on about this. It's so like so many things that we talk about where you swing too far into one direction. There are many times where a non-OB trained anesthesiologist who really doesn't care about the patient experience just puts people to sleep because that's what they're used to doing all the time. Who cares that the patient wanted to be awake? Oh, I don't want to try redoing that epidural. I'm just going to put her to sleep. And that's not good either. Then we say, as OB anesthesiologists, we're the experts in epidurals and spinals. We know how to put in an epidural that works. We know how to give doses of medications that make that epidural work. And that's a sense of pride for us, is we don't have to put people asleep because we've figured out a way to, most of the time, be able to keep people awake during surgery. So yes, this was a high-risk patient. He's not entirely wrong to say that. But this scenario, the description, no, and absolutely not. She was also throwing up. Another thing I want to point out, putting someone to sleep when they're actively vomiting. I just want to stress the complexity
of how this case was unfolding.
And I don't think that clearly, if she's Heather Nixon's coming out and saying, putting this case out there and really knocking a colleague, it's a big deal. I'm not saying it's not. But the stress and complexity as the anesthesiologist, did he have help? Did he have a resident there? Was he the only one managing this? What was available to him at that time? He did not make the right decisions, but let's say if she's actively vomiting and he did make that decision, you can't really, at that exact moment in time, you can't put someone to sleep as they're actively vomiting. That's incredibly dangerous. You can't do that, right? And she's freaking out. A lot is going on. If it were me, I would, knowing her history of anxiety, knowing her fear going in, having a benzo available is fine. And trying a benzo, especially if she at first was not very clear with what was going on, what she was feeling, try a little bit of a benzo, see if that works. At the same time, you're redosing the epidural. I can add opioids to the epidural. I can add other adjuvant medications to the epidural. I can add more lidocaine. What is her blood pressure at this time? Is there any reason that I'm fearful of adding more to an epidural? That's another thing that I notice is different from an OB anesthesiologist versus a regular anesthesiologist. Sometimes they feel like there's some made up cap for how much medication you can put through that epidural. And I'm not really. Everyone's different. I don't know how tall she was. I don't know what point in her spine the epidural was put in, like where, And so as long as your blood pressure is good, and there's quite a range of dosage that you could give. And so I would have given more medication through that epidural. I would have definitely given an opioid through that epidural. If I thought some element at least was potentially some panic, then a little bit. He gave 5 of midazolam along with all kinds of other stuff, but I would say like 2. And if that didn't work, then I'm saying I'm putting you to sleep. I'm pre-oxygenating and putting the patient to sleep. But the one thing that bothered me was that they didn't talk about redosing the epidural. That was sort of like a missed, a confusing piece of it.
So the text messages that you have received, because I mean, honestly, even just listening it, like myself, it invoked fear. And I feel like, I'm sure text messages that you received were around the fear factor.
No, everyone's just asking me. What do you think?
What do you think?
Did you listen?
Okay, so I think I know what you think, but how would you reinforce to our audience to feel less fearful about a situation like this unfolding? Because
I think I have to talk about it with each situation. Okay. So there's we'll come back and talk about this again, a different story that comes in in the 3rd episode. So this situation in particular is about a patient who had an epidural for labor, and that epidural at some point didn't seem to give her adequate anesthesia. So one thing is putting in epidurals properly, watching the epidurals and making sure they continue to work throughout labor. This is how we avoid generally getting to this point. I would say the testing is a huge, because you brought up, and this comes up in the 3rd episode too, the types of testing, how clear the testing is, and the testing has to be proper or else the testing doesn't matter. I don't like how they said, oh, you could be numb on the skin and not on the inside.
I know, that kind of confused me.
That's not really right. No. I mean, there's the icky feeling. Right? We've talked about that. So that's not, the icky feeling is not pain, that's discomfort. And if you have an adequate height of your block, so up to your nipple line, you may still feel icky and weird with things moving around, but that is not, help, I'm in pain, I feel burning, screaming, all of that. That is not going to happen with the icky. Like that icky is just to warn you that there can be like that sensation. So if they truly were numb, the test was done to the appropriate level, sensory level. We talked about the pain fibers. You have to understand this. I don't think, they said he did to pinprick, right? I don't use pinprick. Maybe some people do. I find that it's much more clear with the cold, but you have to know that if the cold is at one level, then the actual pain, which is different than the pinprick, are going to be all different. And so like if someone's actually testing it and understands these nuances and it's so clear to that patient, here's my other thing.
Okay.
Was she moving her legs? I've been using that a lot recently.
Interesting.
Whenever my testing is not, it's funny. It's not clear. It's not like, this happened to me the other day. I always say the other day. It could be any time in the past, but
recently,
where I did a spinal, planned C-section, and I did the spinal. Sometimes, there's trainees or something. She was a little taller, but it seemed perfectly fine. And she had the funniest block. She was like, I can actually move my right leg. Or she was like, just moving. And I was like, what about your left leg? No. And I'm testing her, and we're both looking at it together, and I was like, I have no idea what happened, but something is funny. And like she would say, I still kind of feel a pinch. Like it wasn't she was screaming in pain, like if she had no block whatsoever. But I was like, there's no way I'm going forward.
Right.
You want to be awake for this birth. I knew she wanted to be awake for this birth. I put in an epidural. I started dosing the epidural. She's like, I think it's working. I think I'm starting to feel more numb, but it wasn't convincing. The testing we kept wanting to think that the testing was right. And I said, nope, I took that epidural out. I put in a 3rd epidural.
Wow.
Okay?
Yeah.
And I felt so bad that I had that, we're taking forever. We went back, told the husband everything's fine, And she had scoliosis, but who knows, right? 3rd epidural, I start dosing it, and it's you know that it's working. When it's working, it's working. There's no question about it. She knew, I knew, we all knew it was fine to proceed. And so then we did, and it was a planned, it wasn't emergent. We had all this time to play with things, but it's just, we have to get better at testing our blocks. As the patient, it's not up to you. This is what comes up later in later episodes. But again, as a patient, I would just say, I would move the legs, not the toes, the knees, lifting them up off the bed. That has been, for me, when I just have any question about anything, I can't go on if you can lift your leg. We got to figure something out. We got to do something else out. So I told you I test with cold.
Oh, yeah.
And it got me thinking, I feel like even with patients who have a language barrier, they're just so like, they're like, no, frio. I'm like, frio or no, you know? Yeah. And they're like, no, 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 yes. Like, right exactly how it's supposed to be. It's happened to me just so many times. It's so clear. But I have, and it's been a while, but I have had a patient where just like, I don't know, cold, not cold, like for whatever, it wasn't clicking in the brain. So then you can go to a different type of test, like have a bunch of them. Right. Then you can try the pinprick. And maybe that, for some reason, like they're just more able to distinguish. But basically, you should feel a change in the sensation from the bottom of your belly up to the top of your belly. And yeah, so I don't know how that reduces the fear. So back to the patient, which is the epidural. I know we've had listeners write in who've had issues with, they were put to sleep or had pain, whatever it is. The goal is to have a working epidural and to use that working epidural and to not subject the patient to an additional procedure. If not, someone just asked me this recently about taking the epidural out and putting a spinal in afterwards. I personally don't do that. There are people that do that. I feel like the risk of giving too much medication and getting a high spinal is not anything I'm ever going to put on my plate as a possibility ever. And then if you give too little, then you're back in the same position you were in where you have inadequate anesthesia. So I always put an epidural on top of an epidural, on top of an epidural if I have to, if I have the time, if this patient doesn't want to go to sleep. And then, and then if you don't have a working epidural and you're sure you don't have a working epidural, then you have to go to sleep. Right. If you had a spinal and your spinal is not working, then you have to go to sleep. Or if at any point the patient requests to go to sleep, you have to go to sleep, period. But this wasn't a low-risk patient, back to her. It wasn't like...
Well, I think that's the important thing to bring up, too, because you can't just sometimes take these stories and...
No, this was an extreme example
in many ways.
Many
complex situations that were going on. And I think that if you're just listening without medical knowledge, this could spiral you.
Well, and they want to make it dramatic.
Of course.
At first I was like, where are they going?
I know, but that's why I
this?
think it's important that we talk about it. I agree. I was like, where are we going with this? Yeah. I mean, at first I thought the babies weren't going to make it. I mean, there were so many different layers to this. And I think that's why it's important that we give some clarity, and more so you, because I'm sure like it feels probably an attack on your profession. And it gets better because I think the best thing about it is that I felt like it was talking about my specialty in particular. It would be anesthesia, and saying like the second episode, I think they were at SOAP conference. I was there. I was at that conference. No way.
Yes, I listened to that talk.
Oh my gosh.
Yeah. And when they went through the people who were
wait, did you know that this was going to be turned into a series?
No. Oh, I had no idea. I was at that talk. I was in New Orleans. Remember I went to New Orleans?
Oh, yeah.
Yeah. And I heard like the voice of my mentor that I've talked about. He was one of the people asking or answering one of the questions when they rotated through everybody. Yeah, it was that part it's kind of cool. But, but I hope that they're portraying that there is a group of people that this is literally, as a specialty, this is what we're trying to improve. We're trying to create these guidelines, change the doses of our medications to make them more likely to work, change our techniques, always improving. And of course, like the person who this was not, they made it clear was not an OB anesthesiologist.
Right.
He was a random night float. He wasn't one of the specialists. And so to that extent, I didn't feel offended because I was like,
this is why you did a fellowship in OB.
Yeah. I'm not that random night float person. And it's important that people listen to us, like as the OB anesthesiologists, that we are the experts in this field. Right. And if someone comes to you and maybe tries to give you a little education and you're a community anesthesiologist working somewhere without OB anesthesia training, understand that we have this background and we're there's a reason for it, I guess. There's a reason we're making these recommendations. Just because you've done things the same way forever doesn't mean that we don't need to be changing and making these improvements.
Right.
And it's not, I'm all for the put your foot down. Like, we need to listen to women. This is not okay. So that's enough for me to be happy overall with the series.
And so as a patient, if you listen to these episodes and you are feeling fearful, move your legs, try to move your legs. That would be your number one piece of advice while they're on the...
Make sure it's the same I've said before. Make sure anesthesiologist tests your block. Try to move your legs. Communicate if there's any, use clear words. I've said, pain, if it's at all pain, call it pain.
Right.
Ask for an OB anesthesiologist.
Well, that was going to be my other...
And don't let this fear, all the time, every single day, I see patients who have no pain during their C-sections. I was one of those people who had no pain during my C-section. You had no pain during 3 C-sections.
Right.
Don't let this make you spiral, I guess, is the point.
Yeah.
And reach out to us if you, please, I would love to hear if anyone has any questions after listening to that or has experienced something like this. And
maybe we should put out on our Instagram to say if this is a concern for you, please get clarity from Dr. Jen.
Something you're still working through, advice to tell your next anesthesiologist. Always, 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 if you've been through something that wasn't quite right the first time, make sure everybody knows about it, even if it's just so they can help you mentally prepare and, work through those feelings. But you never know. There might be something that they're going to change as far as their anesthesia plan to make, make sure whatever happened to you didn't happen again. Communicate and reach out to us. I want to hear from you. I want to hear your stories.
Thank you for clearing it.
Yeah.
I was feeling very on edge about it. Now I feel better about it
after
our conversation. I
do. Think of more questions because I could talk about this all day and all night.
Okay.
Okay.
We'll come back to it, Jen.
All right.
All right.
Thanks everyone for listening. We'll see you next week.
Bye.
Bye.